Hello, good evening, Dr. Srinivas.
All on a Saturday evening, and I truly appreciate your enthusiasm and energy to come on a Saturday evening to attend this webinar. In the next hour or so, we'll be discussing some of the recent concepts in our understanding of where ovarian cancers arise from and how does it translate to the growth potential or the biological behavior of various tumors, and how it impacts how we manage many of these patients. So over the next hour or so, we'll see a lot of images because that's what we are interested in. A wide spectrum of benign and malignant ovarian masses, and as alluded to, some of the recent advances in histogenesis and pathogenesis of various...
Prasad, you could share your screen.
Oh, I'm sorry. I thought I was... I'm sorry about that. Okay. Is this good?
Yes, perfect.
Okay. So, and also we'll describe some of the salient imaging findings of characteristic ovarian masses. First, we will start with the role of imaging of adnexal masses. One of the important things that we need to glean from patient history about the demographics and the clinical background of patients, which is important. In case of ovarian masses, it's also important to obtain, is there a family history of ovarian cancers or any other tumors related to the GYN tract? And then we need to find the right imaging test, and we need to correlate with specific laboratory findings. In many of these patients, CA-125 is a great marker for malignancy. And there are specific other hormones and protein markers for specific subtypes of rare ovarian tumors. And for us to, after we find the right test to determine the organ of origin, where exactly is it arising from, because most of them will appear as adnexal masses. So we need to connect the dots in terms of whether it is ovarian in origin or extra ovarian in origin. And then come up with a pattern-based approach to various masses based on imaging characteristics. And also important to look at the old scans to see for any changes in tumor morphology or size. One of the important things to identify where the tumor is arising from in terms of an exophytic uterine leiomyoma, because we see it on this sagittal T2-weighted MR, the specific attachment of this leiomyoma to the uterus. On the other hand, this is a T2-weighted image showing a diffusely hypointense mass posterior to the uterus, which turned out to be a fibroma of the ovary. So one of the other ways of identifying the organ of origin is to trace the ovarian vessels. So if the mass leads to the ovarian vessels, it's likely ovarian in origin. And in addition to finding the obvious connection with the various organs, including you may find an exophytic gastrointestinal stromal tumor arising from one of the small bowel segments within the pelvis, or uterine leiomyoma. So it's important to identify a particular organ of origin, which helps us with the differential diagnosis. The age of the patient is important in pediatric and young adult women, less than 30 years. Most often, we tend to see the rarer tumors that we don't necessarily see in older women. So the non-epithelial tumors, ovarian tumors, tend to be predominant in patients less than 30 years. In patients who are more than 40 to 50 years, we tend to see a wide spectrum of epithelial tumors, as well as ovarian metastasis, as in this the last case on the right. It's important to identify the family or personal history of the patient. Here are two scans separated 6 months apart, and there is a small right ovarian cyst, which 6 months later, we see a larger cyst with some dependent high density. So in a sporadic patient, you could potentially follow it, but this patient had BRCA or BRCA gene mutation, so she elected to undergo prophylactic salpingo-oophorectomy, and this was a high-grade serous carcinoma. And one of the other important things is to go back and look at the images. So this is what happened in this patient. Patient had pelvic pain, and she had what looked like quite plump ovaries. And she subsequently, for monitoring of these so-called plump ovaries, she had an MR, and this is what it looked like. Quite heterogeneous, but somewhat maintained follicles at the periphery of the ovaries. So again, it was again referred to what I refer to as the plump ovaries. And then subsequently, unfortunately, a year later, this is what we see. It had already invaded the uterus, and this turned out to be primary lymphoma of the ovaries. So it is important to look at the prior images to see if we are identifying the tumors. So this was a solid tumor, which was kind of missed, partly because of the presence of peripheral follicles. Again, one of the important things is to know a particular history of a clinical syndrome. This was a patient with granulosa cell tumor of the ovary with associated Budd-Chiari syndrome. And this was an interesting patient who presented with carcinoid heart syndrome, and the primary was in the ovary, heterogeneously enhancing solid mass in the midline, on which turned out to be the case that it was referred to as a uterine leiomyoma, because it was considered midline and probably connected to the uterus. But this patient had presented with carcinoid heart syndrome, classic findings of passive hepatic congestion with heterogeneous midline mass. And this patient with hyperthyroid symptoms was found to have a struma ovarii. And this was a patient who had elevated beta HCG levels due to a primary ovarian non-gestational choriocarcinoma. These three patients presented with specific clinical syndromes. The first case is that of a granulosa cell tumor of the left ovary with coexistent endometrial carcinoma due to the hyperestrogenism. And also, importantly, there was red degeneration of the fibroid, which is a complication of fibroid due to hyperestrogenism. We typically see that in pregnant women undergoing red degeneration of the fibroid, but this was red degeneration due to the elevated levels of estrogen. And this was a patient who presented with hyperandrogenism, hirsutism, and other things. This was a patient with a steroid cell tumor. Again, this was called as an exophytic fibroid in one of the prior imaging. So it is important for us to identify and make sure that it is not a fibroid that we're dealing with, but by the time she presented, she already had features of Meeks syndrome. And again, this is a patient with stroma ovarii, a complex cystic mass with enhancing soft tissue components with increased or elevated or abnormal thyroid function tests. Here is a snapshot of specific syndromes and some of the ovarian tumors. In general, it's the sex-cord stromal tumors of the ovary that are classically associated with specific syndromes, including hyperandrogenism, hyperestrogenism, and Meeks syndrome. So it's important for us to identify specific syndromes so that we can potentially alert the clinician as to the possible histopathology of the tumors. Another important thing is the hypercalcemia, which is seen in patients with clear cell carcinoma of the ovary. And also there's a specific subtype of small cell carcinoma of the ovary of the hypercalcemic type. These are rare tumors, but it's important to consider, especially in the context of hypercalcemia. From an imaging standpoint, we can categorize tumors based on what they're made up of. We can either see fatty masses that may be of varying histopathological maturity, as to say, because you can have a mature or immature or malignant teratoma that may manifest as fatty masses. And there's a bunch of ovarian masses with predominant fibrous content, such as fibrothecoma, fibroma, and these have a specific imaging both on CT as well as MRI. And what I refer to as the bloody masses, where you could potentially have either a hemorrhagic cyst or endometriosis associated cancers that appear as hemorrhagic masses on particularly on ultrasound and MRI. And as usual, cystic masses, most ovarian cancers manifest as multilocular complex cystic masses with soft tissue components. And some of the so-called sex-cord stromal tumors typically manifest as solid masses, predominantly solid masses. So here are some examples of mature teratoma in which you can have a complex cystic mass with what are referred to as the so-called cheese balls with or without acoustic shadowing. And here are more cheese balls filling up the entire cystic area. And one of the common thing is the tip of the iceberg, that commonly some of these tumors were mischaracterized as ball gas. So it's important to consider that whenever you see an echogenic mass with distal acoustic shadowing, mature teratoma is something that needs to be considered. Again, with CT and MR, it's the presence of macroscopic fat with or without calcifications and cystic components that clinches the diagnosis of a mature teratoma. And here are T1 weighted images, one with fat saturation in the bottom and without fat saturation in the top, showing hyperintense masses with so-called fat fluid levels, and there is diffuse loss of signal on fat saturated sequences, confirming the presence of macroscopic fat. Here is an example, both CT and MRI, of a patient with so-called immature teratoma. Immature because it has immature embryonal tissue, particularly neuroepithelium. And these patients may develop what is referred to as the gliomatosis peritonei, whereas it is the proliferation of the neuroepithelium throughout the peritoneum. In contradistinction to the mature teratoma that we have seen, where there is significant proportion of macroscopic fat, here there is admixture of diffusely infiltrative soft tissue with small volume of macroscopic fat and diffusely scattered amorphous calcifications. So this is how it looked on a T2 weighted MR. And you need to look at in-phase and post-phase or fat-saturated sequence to identify macroscopic fat on MRI. And these are examples of the peritoneal and dissemination of immature teratoma with associated scalloping of the liver. So in essence, we need to distinguish between so-called benign teratoma from malignant teratoma. So you could potentially have a macroscopic fat containing mass with some small volume of enhancing soft tissue at the Rokitansky protuberance. So that's the area where there is the marked heterogeneity of calcifications, enhancing soft tissues, fat, or cystic component. They're all admixed. In contradistinction, this was a patient who had a long-standing mature teratoma, and on the subsequent scans, there was this enhancing soft tissue that was developing in the posterior aspect of the mass. And finally, it was taken out, and this was a malignant teratoma with a squamous cell carcinoma component. Not all fatty adnexal masses or peritoneal masses end up being one of the three categories of mature, immature, or malignant teratoma. Here is a patient with, as you see on the out-of-phase images, there is India ink artifact, and clearly this patient had a fatty mass in the peritoneum, and this was a patient who had a prior surgery for immature teratoma in the pelvis and who subsequently developed so-called mature teratomas. So this is referred to as the growing teratoma syndrome, in which the primary source in the ovary might be an immature teratoma or mixed germ cell tumor, but then you tend to get mature teratomas during or after chemotherapy for gonadal GCTs, and the tumor markers are normal. Moving on to fibrous adnexal masses, you can have a diffusely hypointense or low signal intensity mass on T2 weighted images. that are characteristic of a fibroma. You may have a fibrothecoma in which it's a heterogeneous mass with predominantly low signal intensity, but also scattered T2-weighted high signal intensity. And this is a rare case of a fibromatosis of the ovary, where you may have scattered follicles within the ovary, but the whole of the ovary is replaced by fibromatosis. On CT, they appear as low dense lesions or hyperdense lesions, uniformly hyperdense lesions or fibromas, and fibrothecomas may have heterogeneous contrast enhancement. And this was the same case of a fibromatosis where there is intense enhancement of the mass. Moving on to the so-called hemorrhagic bloody masses, you may have low-level echoes, or you may have complex multilocular cystic lesions with echoes. MRI is an elegant modality for the diagnosis of endometriosis. On non-fat saturated and fat saturated, they maintain the same high signal intensity. And on this side, there is diffuse low T2 signal intensity, referred to as the T2 shading because of the varying components of blood breakdown products within endometriomas. There are two classic theories. One is the so-called the retrograde menstruation theory of Sampson that he proposed way back in 1927. And according to this, it's the endometrium, the lining, the endometrial cavity, the functional endometrium gets deposited onto either the tubes or the ovaries, and leading to development of so-called endometrioma, or the chocolate cyst on the ovary, and deep infiltrative endometriosis if it's deposited in other pelvic organs. One of the drawbacks of this implantation theory is its inability to satisfactorily explain the deep infiltrating endometriosis of the pelvic organs. So one of the current theories that's going around is the so-called stem cell theory, in which they're both hematogenous, or the bone marrow, as well as some of the stem cells within the uterus that kind of undergoes either hematogenous or direct contiguous spread to other pelvic organs. As already shown examples, some of the characteristic findings is the presence of lower level echoes within the ovarian lesion, and high signal intensity on T1 weighted images with characteristic T2 shading on T2 weighted images that are characteristic for endometriosis. In contradistinction to the so-called the chocolate cyst, the deep infiltrative endometriosis can have predominantly fibrotic signature with some high T2 signal intensity admixed with it. So this is a patient with associated involvement of the urinary bladder, and this was a diffusely enhancing mass in relation to the right ureter, the urethral deep infiltrative endometriosis, and here is another case that extended into the rectum. So some of these masses can look like nasty malignancies, but you will come to know the histopathology after surgical resection, and these are all cases of so-called tumefactive endometriosis that looks almost like any other garden variety cancer or sarcoma of the pelvis. Now moving on to the classification of ovarian cancers. This is where, until now, we have seen a whole bunch of various interesting tumors. And now we come to the era of molecular classifications of ovarian cancers. Until now, in most other organ systems, it's the morphological way of, but now in almost all organ systems, there is almost exclusive use of or increased use of molecular biomarkers, both immunohistochemical or genetic markers of ovarian or any other organ system masses, so that the new paradigm is moving from a morphological classification system to morphomolecular classification systems. There are, as already kind of briefly touched upon, there are three main categories of ovarian tumors: the epithelial, the sex cord stromal, and the germ cell tumors. First, I would go into the epithelial cancers. These are the most lethal gynecological malignancies, and 90% of all ovarian cancers are of the epithelial type. And unfortunately, despite being quite deadly, most of these patients manifest at a very high stage of disease, and most of them die within 5 years of diagnosis. And we all know this, that ovarian cancer is not a single disease, but from a management standpoint, we consider almost like they were all managed as if it is one single disease. And clearly, based on histopathology, and now bolstered by the genetic abnormalities in each of these are fundamentally different cancers with different histogenesis and different biological behaviors, and not only different under the microscope, but also based on the specific genetic abnormalities. So one of the pathologists would explain to me like this: there are two serous cancers that are fundamentally different from each other, the high grade and the low grade. The high grade is the most common and the most lethal, and the low grade is quite indolent. And there are two kinds of endometriosis associated cancers that develop in the context or background of endometriosis: the endometrioid and the clear cell carcinoma. And there are two kinds of mucinous cancers. Most mucinous cancers of the ovary are metastatic, and the primary mucinous carcinoma is a small percentage of the overall prevalence of ovarian cancers. Less than 5% is primary mucinous carcinoma of the ovary. And what's interesting is that almost 10 to 15% of ovarian epithelial cancers occur in patients with a hereditary predisposition. Two main ones are the BRCA1 and 2, or the breast cancer antigen gene abnormalities. They present with both breast and ovarian cancer syndromes. And the other one is the so-called Lynch syndrome, which is the hereditary non-polyposis colorectal cancer syndrome. As we notice that a sporadic lifetime risk is 1 to 2%, it increases to almost 12% in patients with Lynch syndrome, and 20 to 30% in BRCA2, and 40 to 50% of patients with BRCA1 mutation. Here is a garden variety high-grade serous carcinoma in a patient with BRCA1, quite significant pelvic disease, bilateral ovarian complex masses with enhancing soft tissues, and disseminated peritoneal carcinomatosis. Characteristic high-grade serous carcinoma, the most common and the most lethal of all ovarian cancers. And this is a patient, an interesting presentation in a patient with BRCA2 syndrome, in which there was significant peritoneal metastasis and omental masses. But if you look at down in the pelvis, there are only these small ovarian cysts. So there can be a discrepancy between the pelvic disease, the volume of the pelvic disease, and the volume of peritoneal dissemination. So it's important to consider high-grade serous carcinoma. So for a long time, the popular concept in ovarian carcinoma pathogenesis was that it is the cortical inclusion cyst that give rise to most of these cancers. And it was the surface epithelial cells that give rise to this wide spectrum of epithelial cancers. So many of these patients with hereditary syndromes, they would undergo prophylactic salpingo-oophorectomy, and the pathologist would look carefully at the ovaries to try to understand the pathogenesis of these high-grade serous cancers in these patients in order to identify precursor lesions and other things, but they were largely unsuccessful. Finally, in early 2000s was when a group of European, I believe it was the Dutch pathologists, who said that, geez, we are getting all these samples of fallopian tubes and ovaries, and we are dissecting only the ovaries and throwing all these tubes away. So maybe we should look at the tubes. And this is when they found the so-called precursor lesions, referred to as the serous tubal intraepithelial carcinomas, or carcinoma in situ within the tubes and not within the ovary. So the so-called stick lesions are the ones that develop within the fimbrial end of the fallopian tube. And once it becomes invasive cancers, they spill onto the ovaries, and some of these then become the so-called high-grade serous cancers. So in essence, we were looking at the wrong end in these patients with hereditary high-grade serous cancers. Now it is the current understanding that almost all high-grade serous cancers in patients with BRCA syndromes or hereditary predisposition, they arise from the fallopian tube. And most, if not all, high-grade serous cancers, which is the most common subtype of ovarian cancers in the sporadic setting, also arise from the fallopian tubes. So in essence, we are looking at a cancer that originates within the tubes and then spills on to the peritoneal cavity. So that's why early diagnosis of these cancers are almost impossible, because once it gets onto the so-called highway of the peritoneum, there is peritoneal dissemination parallel to the amount of disease on the ovaries. Here are some examples where so-called high-grade serous cancers. You notice that this is the high-grade serous cancer. It's on the surface of a normal-looking ovary. Same case, different plane, what looks like a normal ovary, but here is the cancer on the surface of the ovary. And again, another example, we have central so-called normal ovaries that's surrounded by tumor. So high-grade serous cancers typically on the surface of the ovaries. And here are some examples of the so-called high-grade serous cancers with tubal malignancies that we see very clearly on these CT images, that there is hydrosalpinx and enhancing soft tissue within it. So some examples to at least on imaging to suggest that these tubal cancers are what leads to so-called ovarian cancers. Here is another example of a hydrosalpinx with high-grade serous cancer occluding the tube. So it is important because these are genetically unstable tumors, and based on the specific pathways, and they respond really well to platinum-based chemotherapy as well as so-called PARP inhibitors that are very active in patients where the DNA repair mechanism is defective. In contradistinction to the so-called high-grade serous cancers, the low-grade serous cancers arise from precursor lesions such as cystadenoma and serous borderline tumors, and they progress in a stepwise progression, just like you find adenoma to carcinoma sequence in colorectal cancers. And one of the other characteristics is the presence of so-called psamomatous calcifications, both within the pelvic or the ovarian masses, but also whenever there is a dissemination within the peritoneum, you see the classic psamomatous calcifications in patients with low-grade serous cancers. Now we know that ovarian cancers develop from microscopic and macroscopic precursor lesions. And whenever we have subtypes of ovarian cancers from microscopic precursor lesions, we will not be successful in based on imaging surveillance or screening modalities. If the subset of ovarian cancers that develop from macroscopic precursor lesions, that's where imaging screening may help in identification of the tumors. In general, as already alluded to, high-grade serous cancers from microscopic precursors within the tube, as opposed to the low-grade serous cancers that arise from cystadenoma or adenofibroma or serous borderline tumor. And very similar to the low-grade serous cancers, the mucinous carcinomas also arise against the background of either cystadenoma or borderline tumors. Here is an example of bilateral multilocular complex cystic masses. And when it came out, it was a metastatic mucinous cancer from the appendix. Here is another example of a unilateral, predominantly unilateral complex cystic mass. And this was due to a cancer in the sigmoid colon. So the caveat is that whenever we see complex adnexal masses and we assume that it is ovarian in origin, we should carefully look at the gastrointestinal tract to assess for cancers. And most mucinous cancers of the ovaries are metastatic in origin. And the primary mucinous cancers are quite rare. They comprise maybe around less than 5% of all ovarian cancers. Primary mucinous ovarian cancers can have various precursor lesions, including mucinous borderline tumor, as in this case, or they commonly also develop in the context of background Brenner tumor or a mature teratoma. And moving on to the serous and the, we are done with the mucinous and the serous cancers, and now on to the so-called endometriosis-associated cancers. So the longer the endometriosis stays within the body, the larger it becomes, the more there is a risk for malignant degeneration. There are sequential genetic changes that cause the malignant transformation from a so-called benign endometrioma to so-called atypical or cuboidal endometriosis to finally malignant endometriosis. So there are characteristics, some of the genetic changes that will propel from the transformation of endometriosis to endometriosis-associated cancers. Almost 90% of the endometrioid variant of ovarian cancers are associated with endometriosis. Almost 50 to 75% of all clear cell carcinomas of the ovaries are associated with endometriosis. As you notice that the high T1 signal intensity is the background endometriosis, and there is varying levels of infiltration or replacement of the endometriosis by enhancing soft tissue mass. Sometimes it may start out as a small nodule that may herald the change from a so-called endometriosis to endometriosis-associated ovarian cancers. So many of the ovarian tumor talks are incomplete without Venkat Subbaya's graphic presentations and also some of the cartoons. And these are very helpful for us to understand, how endometriosis, through a variety of genetic changes, become either endometrioid or clear cell carcinomas. Again, interesting imaging perspective of this was an endometriosis-associated endometrioid carcinoma, and on the left side, it arises against the background of cystadenofibroma. So interesting endometriosis-associated cancers. And another example of a tumor with background cystadenofibroma as opposed to background endometriosis in the same patient, two different pathological context of different backgrounds of abnormalities. So now more and more, as already alluded to, the pathology is moving towards a so-called morphomolecular classification systems based on the genetic changes. And we know that the high-grade serous cancers that arise from the tubal intraepithelial carcinomas, they have fundamentally different genetic changes from the low-grade serous cancers. So unfortunately, most of ovarian cancer patients used to receive the platinum-based chemotherapy. So thinking that hopefully we can cure ovarian cancer by the same drug, but they are driven by different genetic changes, as in this case, the TP53, almost 80 to 95% of all these patients will have TP53 mutations, and the low-grade serous and the mucinous carcinomas are driven by the KRAS gene mutation. So now there is more of a trend towards developing newer drugs based on the specific pathway, so that we can better have a handle on the control of these cancers. And same is the case with endometrioid and clear cell. Even though they arise from the background of endometriosis, they have different genetic abnormalities. So based on these, they're coming up with specific targeted therapies to treat these patients, as opposed to just using one Brahmastra, which is the platinum-based chemotherapy. So it's important to understand that ovarian cancer is not a single disease, but a variety of fundamentally different cancers that are driven by different genetic changes that look different under the microscope, and they behave differently from each other. And the response to chemotherapy also is determined, because most of the mucinous, low-grade serous, and the clear cell cancers are resistant to platinum-based chemotherapy. Now we need to come up with specific pathway-specific chemotherapy. And as you notice that the high-grade serous cancers, the most common subtype, arises from the tubes. The endometriosis-associated cancers, which comprise around 25% of all ovarian cancers, arise from the endometrium. So most epithelial cancers arise from extra-ovarian in origin. In other words, the ovarian epithelial cancer is an imported disease of the ovary, not specific to the ovary. Based on the genetic abnormalities, as I showed you another case of a high-grade serous cancer that responded extremely well. Here is a patient with large omental masses, and that really melted when they used platinum-based chemotherapy and added the PARP inhibitors. So these are the new drugs in ovarian cancers, and this was the first FDA-approved biologic agent for ovarian cancers. In contradistinction, the low-grade serous cancers don't respond well to platinum-based chemotherapy. Here is a patient who had totally different loci of disease on different scans. So some of these patients will have a long-standing cancer disease. And same is the case with clear cell cancers that are really resistant to platinum-based chemotherapy. Here is another patient that had clear cell carcinoma and just continued to grow despite platinum-based chemotherapy. So these are the patients that will benefit from a pathway-specific genetic pathway-specific chemotherapy, or the so-called targeted therapeutics. So one size fits all will not work in many of these patients. So just to summarize about the epithelial cancers, most ovarian cancers arise outside of the ovary, and it's an important disease of the ovary. And as already alluded to, different subtypes will have different biological behavior and different responses to chemotherapy. Now, there is increased interest in understanding the genetic makeup of the so-called non-epithelial ovarian tumors. And again, these are some rare hereditary sex-cord stromal tumor syndromes that are associated with specific histopathology. For example, in patients with Dicer-1 syndrome, they get Sertoli Leydig cell tumors, and classic calcified fibromas are seen in patients with Gorlin syndrome, again, another rare tumors. And in patients with Peutz-Jeghers is what we see are hyperechoic or calcified lesions within the ovary that are the specific subtype of sex-cord stromal tumor in these patients. And in certain sex-cord stromal tumors, we can make the prospective diagnosis. Here is a patient with higher signal intensity on in-phase than on the out-of-phase images, suggesting the presence of microscopic fat. And this was a patient with steroid cell tumor in VHL syndrome. So there are specific genetic syndromes that are associated with specific histologic subtypes of non-epithelial or sex-cord stromal tumors. And some of them have characteristic imaging findings that will allow us to make the diagnosis. And more importantly, what's happening in the world of non-epithelial tumors is that once they know what genetic abnormalities are driving the different tumors, notice that the mutations that are associated with the non-epithelial or the sex-cord stromal tumors are totally different from what is happening in the ovarian epithelial tumors. Particularly the high-grade serous cancer, the most common subtype and the most lethal subtype of ovarian cancers. So clearly, if you have a patient with a rare cancer or a non-epithelial cancer with peritoneal dissemination, using the same platinum-based chemotherapy will not work because they are driven by different mutations. So now they're coming up with specific drugs that target the specific tumor pathways based on the knowledge of these specific genetic pathways in some of these tumors. So in general, I've tried to give an overview of ovarian tumors, both epithelial and non-epithelial, about the various tissues of origin of epithelial cancers, or in the case of sex-cord stromal tumors, various subtypes that are driven by specific genetic mutations, and that have a bearing on how we manage many of these patients with both epithelial and non-epithelial cancers. And thank you all, and truly appreciate you coming on a Saturday evening.
Thank you, Dr. Srinivas. Very comprehensive overview. As I've said earlier, we need to unlearn certain things and relearn or new things. One was about the fallopian tube acting as a harbinger of the primary and seeding the ovaries. That was something really new for us. Do all high-grade serous cancers originate in the tubes, or do they?
Yeah, I mean, as I mentioned to you, I would say at least the pathologists say that almost 99% of all high-grade serous cancers in the hereditary setting, more so in BRCA syndromes, they arise from the fallopian tubes. That's done and dusted. Whereas regarding the sporadic cancers, they say most, if not all. Again, they say 80 to 90% arise from the fallopian tubes. Part of the reason was, again, that the pathologists were just throwing the tubes away and doing the staging and assessment of the precursor lesions in the ovary. So for a long time, they never really assessed the fallopian tubes. So according to the current thinking is that 80 to 90% of even sporadic cancers arise from the fallopian tubes. That's why it's very important, very difficult to catch these cancers early. So we are talking about the so-called low-grade serous mucinous cancers that arise from precursor lesions within the ovary, cystadenoma to carcinoma. Those are the ones that we may be able to hopefully catch. But at the same time, it's extremely difficult to. So that's why most of the screening strategies have failed in ovarian cancers, because the most common one arises from the fallopian tubes. And once it gets on to the peritoneum, there is already peritoneal dissemination. So now the major thing is to identify from lavage of so-called fallopian tubes, identify cells with specific genetic abnormalities such as P53. P53 is the major, the most common in high-grade serous cancer. So that's the next phase of so-called screening, at least starting with the hereditary predisposition and maybe going on to the. So the important implication of that fallopian tube is of twofold. One is in patients with hereditary predisposition of cancers. So they used to undergo prophylactic salpingo-oophorectomy. So at a young age, they would lose their ovaries, leading on to bone disease, osteoporosis, and cardiovascular morbidity. Whereas now with this knowledge, they're doing salpingectomy as a prophylactic one. They will leave the ovaries until she becomes postmenopausal and then remove the ovaries then. So this way, in order to protect the health of the woman with hereditary predisposition. Second thing is, again, in the context of the sporadic population, I think if most women undergo salpingectomy after their reproductive needs are met, we would cut down significantly the ovarian cancers. And most of the deaths are from high-grade serous cancers. So if we take out the tubes, once the reproductive needs are met, I think we will just, if we do it successfully in a large scale, I think we can make a serious dent in
Yeah, that seems to be a pretty bold and radical statement. Yeah. The next
No,
question.
I think that's what is happening. Actually, most of these patients are now opting for salpingectomy because, again, it's mainly the ovaries that maintain the health of the patients. But the salpingectomy is something that can be done as an outpatient.
Yeah. So that brings to my next question about the genetic mutations and the basis of ovarian tumors. What would be the role of imaging and the role of a radiologist in prospectively trying to say a particular mutation, something like in lungs or elsewhere?
No, I think the so-called radiogenomics, I've been watching the field for the past, say, 5 to 10 years or so. People are looking at so-called texture analysis and this, that, diffusion they tried, the ADC maps and all other things. First of all, many of these things have a hard time differentiating benign from malignant, some of these so-called criteria. So in essence, our job is to probably let the clinicians know that, hey, there is a suspicious lesion, you take it out. Or we can definitively say, okay, this is a steroid cell tumor and that's causing the androgenic problem, you take it out. Or this is definitely a cancer that needs to come out. And also, but beyond that, I don't think, at least the technologies that we currently have the ability to kind of predict the so-called genetic mutations in certain things. First of all, many times, unless we have classic, like the cymomatous calcifications with low-grade serous cancers, we can not differentiate between high-grade serous and, let's say, a complex cystic mass in a struma ovarii or any other non-epithelial tumors. So I think we don't have the bandwidth to go into the genetic changes as of now. That's what I believe.
We have a couple of comments in the chat box.
Okay.
Gopal has a question over there. Yes, why do you say epithelial cell ovarian tumors are imported one?
Yeah, as already mentioned, most high-grade serous, which is the most common, is 70% of all ovarian cancers are high-grade serous, and most of them arise from the tubes. 25% of all ovarian cancers are either clear cell or endometrioid. They arise from the endometrium, which is the lining of the endometrium. So it just happens that that's the reservoir where the tumor grows or the cancers grow. So that's why it's an imported disease.
Yeah. What would you think is the role of PET-CT? Does it have any role in predicting the genetic thing, the markers, or in early diagnosis or early, especially in screening programs, that does have a role?
Well, some of the things again, we are talking of early diagnosis, particularly in the context of hereditary syndromes. I think that's where it's important. Unfortunately, even let's say there is something that lights up on PET, a small lesion, and that could be something functional or physiological that can light up on PET. So you cannot specifically say that, okay, the thing that's lighting up is a cancer in the ovary, particularly with regard to physiological. Definitely PET-CT is very helpful in all gynecologic cancers, mapping of the disease, presence of disease that is not typically suspected, and that will change the management. For example, presence of thoracic disease in a patient with GYN malignancy, clearly that requires this one. As far as early diagnosis, I'm not so sure, partly because of the reasons that I mentioned, that most of these hereditary cancers arise from the tubes and spill over to the peritoneum. So it gets onto the highway very quickly. And that's the reason why early diagnosis has always been a challenge for the gynecologists. See, I mean, we have started, when was this so-called high frequency screening of, ovarian cancers? And maybe when I finished my residency, and that was catching up at that point. And now 25 years later, I don't think we have made any dent in terms of, reducing the either morbidity or mortality of ovarian cancers. So that has been a failure. And that's well recognized in the epidemiological circles and even in the oncology, that we haven't really made any significant dent or impact. So I mean, personally, some of the surgeons are currently of the opinion that salpingectomy is the key thing. I mean, partly because it would take out 90% of all ovarian cancers. See, if you take out the tubes, there won't be the incidence of endometriosis associated ovarian cancers also drop. Definitely incidence of high-grade serous cancers also drops. And there are also some pathologists who believe that a subset of even low-grade serous cancers arise from the tubes. So I think somebody with a deeper understanding and knowledge should come up with. I mean, we talk about cigarette being killers, and there's so much public hue and cry, but nobody talks about ovarian cancers in terms of, and this is one thing that will impact millions, if not billions, even in India.
Sir, can I ask a question?
Yeah,
Sure.
please.
Yeah, that was a really wonderful and interesting talk, Dr. Srinivas.
Thank you.
One thing is, like, as Dr. Ishwar had said, we have to really unlearn certain things, because we always thought that if you're able to see a part of the normal ovary, then the lesion is likely to be, at the most borderline, but never malignant. That was one. And the second thing is with the upcoming genetic or molecular markers for all these ovarian tumors. So how are you doing the genetics actually? So because traditionally we have been taught not to biopsy an ovarian tumor. But again, nowadays there are concepts which are coming up that if it is already disseminated within the peritoneum, you can biopsy and look at the genetic markers, then give us something like a neoadjuvant to decrease the tumor bulk. So what is the protocol that you actually follow at your place?
Yeah, I mean, again, I cannot talk about, even my place, because I'm not, predominantly that's driving the GYN oncology thing. But yes, as you mentioned, it is important, particularly in the context of peritoneal dissemination, to nowadays they're biopsying these cancers. And if they know that it is high-grade serous cancers, they go ahead and treat with platinum-based chemotherapy and PARP inhibitors, particularly if there is what is referred to as HR deficient tumors or homologous recombination, or if there is evidence of DNA repair defects in these cancers. So they respond extremely well. So I showed you a case of peritoneal carcinomatosis, and they gave platinum-based chemotherapy and PARP inhibitors, and all the macroscopic disease vanished. So that's what they're doing with high-grade serous cancers. in that, they are upfront giving the chemotherapy to decrease the volume of disease, and then they go in and take out whatever they can, including some of the microscopic foci of disease. So I think that makes a lot of sense, particularly in the context of high-grade serous cancers. In terms of other cancers, again, they use the same Brahmastra, platinum-based chemotherapy for all ovarian cancers. So many of these don't necessarily respond that dramatically as opposed to the high-grade serous cancers. So if it is non-high-grade serous cancers, I'm not sure how much of help it is to do surgery following chemotherapy. But clearly, I think if it is high-grade serous, it makes sense. And that's also the most common subtype of ovarian cancer. So it makes sense in all ovarian cancers, particularly with peritoneal dissemination, to do the biopsy, get the P53 mutations or the DNA repair defects, and then go ahead and treat. So I think that's the right paradigm where we know what the genetic abnormalities are, and we treat the specific tumor pathways.
Yeah, there's another question about follow-up imaging after new therapies. What is the Brahmastra?
I think we use PET-CT and CTs again for many of these. As already alluded to, if it is high-grade serous cancers with specific genetic DNA defective repair, it works like magic. So I think PET-CT is an excellent modality because we may miss some of these. I mean, we have some blind spots on CT scans where we may not pay too much attention. For example, portohepatis area or subdiaphragmatic area where we may not be that good at picking up the deposits or serosal mets. But I think PET-CT is a wonderful thing because we can pick up some of those blind spots.
Is there any, how is the performance of CT versus MR in staging of ovarian tumors?
Well, for the most part, I think the workhorse in most institutions is still CT and PET-CT. MR, it's first of all very difficult to convince the gynecologist to opt for an MR rather than a CT because they think that anyway they will do a clean search and resect operation during surgery. So the key thing is the cytoreductive surgery where they take out all suspicious and obviously all cancers things. So for me, it is excellent for, let's say, characterization of an adnexal mass. So as already alluded to and shown some examples, we can definitely say whether a particular mass is fibrotic, fatty, hemorrhagic, and also, we can definitely pick up the underlying histopathology in some of these classic tumors. In terms of peritoneal, it's a matter of getting used to because again, it's easy for us to miss if we are not very savvy at looking for peritoneal disease on MRs. So for the pelvis, it looks great, but when you combine abdomen and pelvis, sometimes we may, again, it's a matter of getting used to a particular modality. In general, we tend to do much better with CT, partly because we know where to look and how it looks. I mean, ideally, just based on the performance things, they should be comfortable. Because there are some institutions that do exclusively MR, for example, for pancreatic cancer with or without peritoneal dissemination, as opposed to pancreatic CT. That's the gold, the most common workhorse in many institutions. So I think they should, just based on paper, they should do equivocally. Both of them should be somewhat equal in terms of performance. But I think since we do more CT, we have more experience and expertise with CT, that we tend to kind of get a better handle on the peritoneal dissemination part with CT.
Thank you, sir.
Thank you all. Any other, there's another one from Rajgopal.
Yeah, I think salpingectomy is being increasingly performed even in patients with genetic predisposition. I mean, partly because of the thing that I told you, that ovaries are very important for a woman, and for both bone disease as well as for cardiovascular health. Probably better to keep the ovaries till they stop functioning and then remove, because anyway, they may also be harboring potentially microscopic precursors. So I think that's a valid thing, not only in the hereditary context, but also in sporadic.
I think in the sterilization program where women undergo tubectomy, they remove a part of the tube, I guess. I don't think they remove the entire
even
tube.
if, I mean, that's why they're so low among patients who have undergone either tubal occlusion or tubal ligation. The incidence of ovarian cancers is less, partly because of the same mechanism. But I think it should be a public health measure, which will be great, particularly in India, because the cost of having an ovarian cancer, if I were a woman in rural India, it's almost impossible. And the morbidity, the repeated surgeries, repeated testing, repeated small bowel obstructions, and various problems associated with it. I would any day, if I were a woman, would undergo a salpingectomy following the reproductive age.
Any other questions from the audience? Yeah, if there are none, I would sincerely thank you once again, Dr. Srinivas. It was a pleasure listening to the current insights and newer things. Look forward to see you sometime again in the near future. Thank you once again from Crest, Hyderabad.
Okay.
Thank you.
Thank
all.
you.
Good day.
Good
night to all.